Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Willkommen auf dem Kanal für Anästhesie und Perioperative Medizin. Gracias por acompañarnos hoy en el canal de Anestesia y Medicina Perioperatoria. आज Anesthesia और Perioperative Medicine channel पर हमारे साथ जुड़ने के लिए धन्यवाद.
Today, we are going to embark on the complete perioperative journey for a heart transplant patient. It's quite a complex process, so we've broken it down into 6 parts. We'll start with the absolutely critical pre-transplant evaluation and optimization phase. Then, we'll step into the operating room to cover intraoperative management. We'll dedicate a whole section to the high-stakes moment of weaning from bypass, then follow the patient into the ICU. After that, we'll tackle some key complications, and finally, we'll wrap up with a summary and a peek into the future. Let's dive right in. You know, it's often said that the success of a heart transplant is overwhelmingly determined before the patient even sees the inside of an operating room, and that is absolutely true. That's why we're starting here, with the meticulous, multidisciplinary process of preoperative evaluation and optimization. This is where the foundation for a positive outcome is truly built.
So at its core, heart transplantation is the gold standard, the definitive therapy for a select group of patients with end-stage heart failure. These are patients who have already exhausted every other medical and device therapy available. Now, the landscape of who gets these transplants is dominated by 2 main causes. A little over half of the cases are due to non-ischemic dilated cardiomyopathy, and about a third are from ischemic cardiomyopathy. The entire goal of our preoperative evaluation is to carefully pinpoint the candidates who will truly benefit most from this life-altering procedure.
So who exactly is the right candidate? Well, this table lays out some of the most critical eligibility criteria. Of course, the main indication is advanced heart failure. But beyond that, we look at factors like age, generally keeping it under 70, and BMI, where we're aiming for below 35 to minimize surgical risks. Functionally, a peak oxygen consumption below that 12 to 14 milliliters per kilogram per minute mark is a clear sign of severe limitation. But for us, as anesthesiologists, the hemodynamic parameters are absolutely crucial. We need a pulmonary artery systolic pressure below 50 millimeters mercury, and even more importantly, a pulmonary vascular resistance under 3 Wood units that is reversible. Why is that so critical? Well, you have to imagine the donor's healthy right ventricle. It's just not built to handle the extreme afterload of a recipient's fixed severe pulmonary hypertension. It would fail almost immediately. And of course, we also need to see that other comorbidities, like diabetes and renal function, are well managed to ensure the patient can tolerate the challenging postoperative course.
Now, on the flip side of that, we have the contraindications. Absolute contraindications are the non-negotiables. Things like an active cancer or irreversible damage to other vital organs like the liver. These conditions just make the risk of the surgery and the powerful immunosuppression that follows unacceptably high. But then there are the relative contraindications, and this is really where our optimization efforts come into play. These are serious but potentially fixable risk factors. Things like poorly controlled diabetes, active substance use, or severe obesity are major red flags that have to be aggressively addressed before a candidate can even be listed. They aren't necessarily permanent no's, but they require significant intervention and prove that the patient is ready to take this on.
Another huge piece of this preoperative puzzle is immunological preparedness. Every single candidate undergoes HLA genotyping and screening for what we call panel reactive antibodies, or PRA. A high PRA, let's say over 10%, is a big deal. It means the patient already has antibodies against a large portion of the potential donor pool, which dramatically increases the risk of rejection. Now, where do these antibodies come from? Well, they can come from blood transfusions, which is exactly why we're so cautious with them pre-op, pregnancies, or even from mechanical circulatory support devices. For these highly sensitized patients, we have strategies like desensitization therapy, using IVIG or plasmapheresis to try and lower their antibody levels and give them a better shot at finding a compatible donor.
Physical conditioning is every bit as important as immunological conditioning. We've talked about the BMI cutoff of 35 for obesity, but it's equally important to address patients who are underweight. A BMI under 18.5, or what we call cardiac cachexia, signifies a really poor nutritional reserve. This is where prehabilitation becomes so valuable. These are structured, supervised programs that combine exercise and nutritional support. The goal is simple: prevent the physical deconditioning that happens while waiting for a heart, and ensure the patient shows up for surgery in the best possible shape. And all the while, we have to keep a close eye on other organ systems, especially the liver and kidneys, which are often caught in the crossfire of chronic heart failure.
Let's talk about something that's often overlooked but is absolutely critical: hematologic optimization. Anemia and iron deficiency are incredibly common in advanced heart failure. You see them in up to 70% of patients. And here's the key thing. It's not just about the hemoglobin count. Iron deficiency itself, even without anemia, directly harms cardiac and skeletal muscle function. Why? Because iron is a key component in the mitochondrial machinery that produces energy. Without it, the energy factories in the heart and muscles just can't keep up. This directly impacts exercise capacity and is an independent predictor of poor outcomes. So because of that, our approach has to be proactive. We screen regularly with a full blood count, ferritin, and transferrin saturation. When we find iron deficiency, the treatment of choice is intravenous iron. It's just so much more effective than oral iron, which is notoriously poorly absorbed in these congested patients. And this is really important. We do everything we can to avoid blood transfusions. Remember, transfusions are a primary source of HLA sensitization, which, as we just discussed, can make finding a compatible donor much, much harder. Giving IV iron is a far safer and more targeted strategy to get the patient ready.
Okay, so our patient has been meticulously optimized and a donor heart is on its way. We're now heading into the operating room. This next section will focus on the key principles of our intraoperative anesthetic management.
Before we even think about induction, the setup is extensive. We go far, far beyond the standard ASA monitors. An invasive arterial line is non-negotiable for beat-to-beat blood pressure. A pulmonary artery catheter, or PAC, is absolutely indispensable. It's our direct window into right heart function, pulmonary pressures, and cardiac output, and that information will be vital for managing the new graft. Transesophageal echo, TEE, is equally critical. It lets us directly visualize cardiac function and diagnose any problems in real time. And of course, having robust, large-bore IV access is a given, as is getting the right antibiotic prophylaxis on board.
You could argue that induction is one of the most dangerous moments for these patients. They have virtually no cardiac reserve. Many are dependent on high levels of their own circulating catecholamines just to stay alive. So our anesthetic plan has to be meticulously designed to avoid three things: profound hypotension from vasodilation, any further depression of their already failing myocardial contractility, and any spike in their pulmonary vascular resistance. It's a true balancing act, often involving a combination of agents like etomidate or high-dose opioids given in tiny, titrated doses, all while having vasopressors drawn up and ready to go.
While we're carefully managing the hemodynamics, the surgical team gets to work implanting the donor heart. The most common technique used today is the bicable approach, which does a better job of preserving the recipient's natural atrial geometry. The sequence of connections is very logical. First, the left atrium, which allows the heart to be de-aired. Then the IVC, the pulmonary artery, and the aorta. Once that aortic cross-clamp is removed and the heart gets reperfused with blood, the final connection, the superior vena cava, is completed. Understanding this sequence helps us anticipate key moments, especially that critical reperfusion event. And now we arrive at what is arguably the most critical phase of the entire operation, weaning from cardiopulmonary bypass. This is the moment of truth. This is when the new, denervated, and often stunned allograft has to take over the body's entire circulation. How we manage these next few minutes can truly define the patient's entire postoperative course.
This is the fundamental question we have to answer before we even think about turning down those bypass flows. We are literally asking a heart that has been sitting on ice for hours to instantly perform at its absolute peak. So the big question is, how do we know if it's ready for that challenge?
Weaning from bypass isn't just a single event, it's a systematic process. Before we even start, there's a whole checklist of physiologic prerequisites that must be met. The patient must be warm, with a core temp above 36 degrees. We need a stable, effective cardiac rhythm. Because the donor heart sinus node can be sluggish after being ischemic, epicardial pacing wires are almost always used. We have to meticulously de-air the heart chambers under TEE guidance to prevent a catastrophic coronary or cerebral air embolism. And of course, the metabolic environment has to be perfect. We correct any acidosis, fix electrolyte abnormalities, and make sure the hematocrit is adequate to carry oxygen.
Now, this slide here is basically our pharmacologic toolkit for that post-bypass period. It is extremely rare for a new allograft to come off bypass without needing some kind of support. We choose our agents based on the specific hemodynamic problem we're seeing on the PAC and the TEE. So for example, if the primary issue is poor contractility combined with high PVR, which is the classic setup for RV failure, an inodilator like milrinone is a fantastic choice because it both increases contractility and decreases that PVR. If we have isolated left ventricular dysfunction, maybe dobutamine is a better choice. For low systemic vascular resistance, norepinephrine is our workhorse. And for that severe catecholamine-resistant vasodilation, vasopressin is key. We often end up using these in combination, constantly tailoring our support to the patient's real-time physiology.
I really want to take a moment to focus on the right ventricle. Right ventricular failure, or RVF, is truly the Achilles heel of heart transplantation. You have to remember, the donor heart comes from a healthy person with nice, low pulmonary pressures. We are then transplanting that pristine, unconditioned right ventricle into a recipient who often has chronic, sometimes severe pulmonary hypertension. This acute afterload mismatch can cause the RV to dilate, become ischemic, and just catastrophically fail. Anticipating and aggressively managing RVF is one of our most important intraoperative responsibilities.
So, our management strategy for RVF depends entirely on the underlying pulmonary vascular resistance. If the PVR is normal and the RV is still failing, the problem is likely graft stunning or maybe just inadequate preload. In that case, we focus on inotropic support and ensuring an optimal heart rate and rhythm with pacing. However, if that RV is failing because it's pumping against a high PVR, our primary goal shifts completely to afterload reduction. This is where inhaled pulmonary vasodilators like nitric oxide or epoprostenol are invaluable. They selectively dilate the pulmonary blood vessels without causing systemic hypotension. If medical therapy fails in either of these scenarios, we have to be ready to escalate quickly to mechanical support, like an RV-AD or even ECMO.
Okay, once the patient is successfully weaned from bypass and the chest is closed, our journey continues into the ICU. The challenges now shift away from the acute surgical events and more towards managing the unique physiology of the transplanted heart and the complexities of immunosuppression. Understanding the physiology of the denervated heart is absolutely fundamental to good postoperative management. During procurement, all the donor heart's autonomic nerve connections are severed. This has some really profound implications. For one, the resting heart rate is now set by the SA node's intrinsic firing rate, which is typically a bit higher, around 90 to 110 beats per minute. But crucially, there is no reflex tachycardia if the patient becomes hypotensive. The heart's only way to increase its rate and contractility is through a much slower, delayed response to circulating catecholamines. This means drugs that work indirectly by blocking the vagus nerve, like atropine, are completely useless. To increase the heart rate, we have to use direct-acting agents like isoproterenol, or more simply, just use the epicardial pacing wires.
Now, to prevent the body from rejecting this new heart, a powerful immunosuppression regimen is started immediately. It begins with induction therapy right there in the operating room, typically with an agent like basiliximab or, for high-risk patients, antithymocyte globulin, along with a big dose of methylprednisolone. This provides a strong initial shield against rejection. This is then transitioned to a lifelong maintenance regimen, which is usually a triple drug cocktail. It typically consists of a calcineurin inhibitor, an antiproliferative agent, and a low dose of corticosteroids. Managing the many side effects of these drugs becomes a major focus of long-term care. Of course, the unavoidable consequence of such potent immunosuppression is a high risk of opportunistic infections. Because of this, prophylaxis is a standard part of the postoperative protocol. All patients will receive treatment to prevent pneumocystis pneumonia, usually with cotrimoxazole. Prophylaxis for viral infections, especially CMV and herpes simplex, is also standard. The specific drug and how long they take it is often tailored based on the donor and recipient's pre-transplant viral status. These preventative measures are absolutely critical for getting patients safely through that vulnerable early post-transplant period. Despite all of our best efforts, the post-transplant course can be very rocky. In this section, we're going to focus on the diagnosis and management of two of the most feared early complications: primary graft dysfunction and vasoplegic syndrome. Primary graft dysfunction, or PGD, is a truly devastating complication. It's essentially a severe acute heart failure of the new allograft that shows up within the first 24 hours. And it's important to note that this is a diagnosis of exclusion. Before we can call it PGD, we have to first rule out other causes like hyperacute rejection, a surgical problem, or uncontrolled pulmonary hypertension. What's left is PGD, which we think is caused by a combination of ischemia, reperfusion injury, and other factors related to the donor heart. The diagnosis is formalized using specific criteria from the International Society for Heart and Lung Transplantation. We classify PGD based on whether it's affecting the left ventricle, or both ventricles, versus the right ventricle in isolation. For PGD-LV, we're looking for objective evidence of severe systolic dysfunction, a low cardiac index, really high filling pressures, and often the need for mechanical support just to maintain perfusion. For isolated PGD-RV, the classic signs are a very high CVP, a CVP to wedge pressure ratio greater than 0.8, and of course, severe RV dysfunction on the echo, often requiring an RVAD.
A treatment of PGD is really a race against time to support the stunned graft and give it a chance to recover. We start with aggressive pharmacologic support. We're talking high doses of multiple inotropes and pulmonary vasodilators. But if the patient remains in shock despite maximal medical therapy, we have to escalate quickly to mechanical circulatory support. VA ECMO is often the go-to modality because it can completely take over the function of both the heart and the lungs, providing a true bridge to recovery for the allograft.
The other major complication we often face is vasoplegic syndrome. This is a form of distributive shock characterized by profound vasodilation and a dangerously low systemic vascular resistance. So the patient is very hypotensive, but unlike in cardiogenic shock, their cardiac output is often normal or even high. You can think of it as a state of vascular paralysis, often triggered by the massive inflammatory response to cardiopulmonary bypass, and it requires a very specific treatment algorithm.
The treatment here follows a very clear stepwise approach. We start with our standard vasopressor, norepinephrine, often at very high doses. If the patient is still hypotensive, we add a second agent that works through a completely different mechanism, and vasopressin is the classic choice here. If that's still not enough, we move to a third-line agent, methylene blue. Methylene blue is fascinating. It directly inhibits the nitric oxide pathways that are the root cause of the vasodilation. In those really refractory cases, it can be dramatically effective.
All right, to wrap things up, let's summarize the key anesthetic principles we've covered, and then take a quick look at how advanced technology, specifically artificial intelligence, is poised to reshape the entire future of heart transplantation.
Let's just boil all of this down to a few key takeaways, the anesthetic pearls you need to remember. First, success starts long before the operating room with meticulous patient optimization. Second, always anticipate and be prepared to aggressively manage right ventricular failure. It is the Achilles heel. Third, you must deeply understand the clinical implications of cardiac denervation. Fourth, become an absolute expert in tailoring hemodynamic support with your full arsenal of vasoactive drugs. And finally, have a clear, pre-formulated plan for how you will manage the major complications of PGD and vasoplegia.
And now, looking to the future, this field is really on the cusp of a major transformation, and it's being driven by artificial intelligence and machine learning. These powerful computational tools are being developed to analyze enormous data sets and find complex patterns that are simply invisible to human clinicians. This is going to bring a whole new level of precision to every single stage of the transplant process.
And this isn't science fiction, it's already happening. As this table shows, research is being published across multiple domains. Machine learning is helping us identify the genetic causes of cardiomyopathy. AI algorithms are analyzing protein signatures in the blood to diagnose rejection earlier and less invasively. New prognostic models are using AI to better predict post-transplant survival, which will improve organ allocation. And AI is even being used to personalize immunosuppressant dosing to maximize the benefit while minimizing toxicity. It's really incredible stuff.
And this brings us to our final thought-provoking question. As these AI tools become more and more accurate at predicting who will do well and who will do poorly after a transplant, how are we going to use that information? How will it change our ethical frameworks around organ allocation? And how will it influence our clinical decisions about whether to offer this life-saving therapy to the highest-risk patients? It's a very complex question, and it's one that we, as a medical community, will need to address as this technology continues to mature. Thank you for joining this explainer.